The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back to Sky Women's Health Podcast. I'm Dr. Carolyn Moyers, board-certified OBGYN, menopause certified physician, and ISHWISH fellow. And today we're diving into a very common and misunderstood question I get from patients a lot. If I'm already on hormone therapy, do I still need vaginal estrogen? And the short answer is many women do. And if you're experiencing symptoms of Genitourinary Syndrome of Menopause, or GSM for short, because that's a mouthful, this episode could change your life. And before we get into the science, I want to start with a story. So I can't tell you how many times a patient sits across from me and says something like, I could care less about sex. Sex feels like razor blades. I feel like I'm tearing when I wipe. I pee all the time. I can't leave my house without knowing where every bathroom is. I'm up 2, 3, 4 times a night to pee. And these aren't minor annoyances. These are symptoms that affect relationships, your sleep, your mood, your confidence, your life. And it breaks my heart that so many women think it's just normal or assume they're too old or they simply don't realize that these issues are treatable, or they go see someone who puts them on testosterone pellets and doesn't treat their GSM. So let's talk about what is actually going on. What's happening to the vulva and vagina in menopause? Here are common vulvar changes associated with GSM. And I want you to hear this because so many women think they're the only one. Thinning and dryness of the vulva skin. So the skin becomes fragile, more prone to irritation, micro tears, and pain. Labial changes. So the labia minora can thin, shrink, retract inward. They often seem to fuse. In more advanced cases, the tissue can fuse and partially cover the vaginal opening, but oftentimes the lower labia, 2/3 of the labia minora, kind of fuse into the labia majora. And the labia majora also can lose volume. There's a decrease in blood flow and a pale appearance to the labia and the vagina. So estrogen loss reduces circulation, leading to that paler skin and flattened tissue. So we start to lose the folds of the vaginal walls. Loss of collagen and elastin. So these proteins give the vulva its structure, and without them, the tissue becomes dry and thin and more easily injured. Increase in itching, burning, and sensitivity are also seen, and these are very common from the dry, thin tissue. Painful intercourse or dyspareunia, often described as burning or scraping or tearing. Reduced sexual sensation because the nerve endings are affected, and an increase in infections. So changes in the pH or the microbiome that can lead to recurrent bacterial vaginosis, to yeast infections, to UTIs, especially after intercourse. And if any of this sounds familiar, you're probably dealing with GSM. And yes, this is incredibly common, even in women who are already on systemic hormone therapy. And let's talk about why. Why does systemic hormone therapy not always fix GSM? This is where most women, and frankly, a lot of clinicians, get confused. So systemic estrogen, so our patch, pill, gel, spray, does amazing things. Systemic, think whole body, does amazing things for hot flashes and sleep and mood, bone health, joint pain, brain fog. But when it comes to GSM, systemic estrogen helps some, but not enough for the majority of women. Studies show that 20 to 30% of women on systemic estrogen still have GSM symptoms severe enough to need local therapy. And honestly, in some studies, 85% of women report experiencing GSM in their lifetime. Now, why is it that people who are on systemic hormone therapy may still have symptoms? Well, systemic estrogen is often too diluted by the time it reaches the vulva and the vagina. So the vaginal epithelium needs a high local concentration. GSM is a progressive condition. It doesn't stop on its own. So without that local estrogen, the tissue can continue to thin. The vulva has fewer estrogen receptors than internal vaginal tissue. And so a more direct treatment is often needed. This is why so many women feel so much better once we add local vaginal estrogen, even if they're already on systemic hormones. So, what percentage of women need both? According to the North American Menopause Society or the Menopause Society and the International Society for the Study of Women's Sexual Health, up to 84% of postmenopausal women have GSM symptoms, and approximately 50 to 70% will require local vaginal therapy with or without systemic hormone therapy. Okay. So I would say this is true in my practice. At least 50% of my patients are on both local and systemic hormone therapy. 20 to 30% of systemic hormone therapy users still need vaginal estrogen for full symptom relief. So, again, up to 84% of postmenopausal women will have GSM. Approximately 50 to 70% will require local vaginal therapy, whether they're on systemic or not. And if they are on systemic, another 20 to 30% still need both for full symptom relief. In my own practice, I would say that 75 to 80% of menopausal women really benefit from both. That means that if your systemic hormone therapy isn't helping with urinary urgency, dryness, burning, or painful sex, you're not broken, your dose isn't wrong, you probably just need a tissue specific treatment. So, what are our treatment options for GSM? And let me just backtrack and say that when I'm approaching a patient, if one of their primary complaints is genitourinary syndrome of menopause, if they're telling me that it feels like sandpaper, that they're unable to have pain-free sex, then I am not waiting to see if their systemic hormone therapy is going to address that. I am treating that locally. Sometimes that's the first thing that we're starting because vaginal estrogen is so extremely safe. That's the first thing we're starting while we're continuing a comprehensive workup for the patient to ensure that they're a good candidate for systemic hormone therapy. So, what are our treatment options? Here we go. Local vaginal estrogen. We have FDA approved options. So, we've got low dose vaginal estrogen is the gold standard, safe, effective, doesn't raise your blood estrogen levels significantly. You can choose the formulation that fits your lifestyle. So, vaginal creams are very popular, I like to call them liquid gold. It comes with an applicator. Generally, the dosing is 1 gram in the vagina 2 nights a week. So that's estrase. It's an estradiol cream at 0.01%. There's also a conjugated equine estrogen Premarin cream that can be utilized. I really don't use it anymore in my practice, but it comes with an applicator that can be applied in the vagina at bedtime 2 nights a week. Some of my tricks are to have patients get the disposable applicators off of Amazon because it comes with one applicator from the pharmacy, and that really icks out a lot of patients. They don't want to spend time cleaning that applicator. It's also really great for applying to the opening of the vagina, to the vestibule or the labia that need direct application. And you can also use a fingertip to apply it or to rub it in. So I like to have patients use the disposable applicators so that we know that we're getting that 1 gram dose and then use a finger to rub it in, just like a moisturizer. Now, your physician may adjust your dosing because it can be titrated up to 2 grams or 3 times a week, depending on your particular symptoms. But that is something that you need to discuss with your clinician. There are also vaginal tablets, estradiol tablets, a 10 microgram estradiol tablet, which is Vagifem is the trade name. It's small, it's discreet, it comes in a preloaded applicator, easy application, 2 nights a week at bedtime. Some patients like this because it's a little less messy, but it is a dry tablet that is going in your vagina and needs to get absorbed. We also have a vaginal insert or suppository, which is Imvexi. It's a 4 or a 10 microgram estradiol capsule that is a coconut oil based capsule. And when it's placed 2 nights a week, again, comfortable, low dose, great for women who are more sensitive to the cream or don't particularly like the mess of the cream. Again, when this hits the body heat, that gel capsule is going to dissolve and you've got your estradiol. It's dosed at bedtime. We also have a vaginal ring that you just place in the vagina. It stays in place for 90 days. It has 2 milligrams of estradiol and it releases 7.5 micrograms per day over that 90-day duration. It's a steady release, great for women who don't want to remember dosing or who have dexterity issues with placing the vaginal cream or tablet or suppository. And this is something that they could come in every 90 days to their clinician and have it removed and a new one inserted, or they can do it themselves if, or a partner could apply it for them, place it for them. Okay, we also have some non-estrogen options. So one is DHEA. It's a vaginal precursor to estrogen and androgens or testosterone. And why is this important? Because the vestibule has a lot of androgen receptors or testosterone receptors. And this is great for individuals who are having painful intercourse. So it's indicated specifically for postmenopausal women who are painful sex or painful penetrative sex. This vaginal DHEA is called prosterone or Interosa and usually requires a manufacturer coupon for us to get it covered. Okay, we also have a non-estrogen option called aspenathin or Aspina. It's an oral SERM, a selective estrogen receptor modulator. It's a type of drug that can either mimic or block the effects of estrogen in different parts of the body. And you've probably heard of these drugs being used in things like breast cancer or osteoporosis. But this one is specific for women with dyspareunia, but it does not treat the urinary symptoms of GSM. Okay, other adjunct or supportive therapies, hyaluronic acid vaginal moisturizers, silicone based lubricants, pelvic floor physical therapy if we have pelvic floor hypertonicity or laxity going on. CO2 lasers like Mona Lisa Touch, not the first line, but helpful for select patients. I'd also love to recommend either vaginal dilation, regular sexual activity, or even with something like the menopause massager, which is a heated vibrator that helps to bring blood flow to the area. And avoiding irritants like fragrances or dyes or anything that can create any type of contact dermatitis or inflammation to the vulva. Okay, again, those are just supportive therapy. So, like my trifecta for a dry vagina is always lube for any penetrative sex. And if we're not an 8, if we're not aroused to a level of an 8, do not penetrate. A vulva moisturizer, like your hyaluronic vaginal moisturizers, via by Solve Wellness is a fabulous one. I also love Medicine Mama's vulva moisturizer. Great options. And then your vaginal estrogen, which is a prescription in the United States. Okay, so back to can you use systemic hormones and local vaginal estrogen? Yes. Not only can you, but most women with GSM should. The North American Menopause Society, the American College of Obstetrics and Gynecology, the International Society for the Study of Women's Sexual Health, and the American Urologic Society all agree local vaginal estrogen is safe to combine with systemic hormone therapy, including women with a uterus. You don't need progesterone coverage for endometrial protection if you're just using a local vaginal estrogen. If you have a uterus and if your systemic hormone therapy indicates you to use a progesterone, then obviously you would. But just for local vaginal estrogen therapy, you do not need a progesterone alone, even when used long term. So, vaginal estrogen is so low dose that it doesn't require progesterone, increase your systemic estrogen levels meaningfully. For instance, postmenopausal women who has her blood drawn after being on a local estrogen is going to have a very similar postmenopausal estrogen range. So, it doesn't increase cardiovascular risk, it doesn't increase breast cancer risk. Actually, and we have studies on this now. Individuals who have a history of breast cancer, is safe for them to use vaginal estrogen. Um, we see no increase in mortality or in incidence of breast cancer with vaginal estrogen use. What are some nuances of adjusting hormone therapy? So, this is where individualized care really matters. You may need more than one tool. So, systemic hormone therapy for your whole body symptoms, local estrogen for your GSM, or DHEA or epinephrine specifically for sexual pain. Another great thing that we use for sexual pain, if it's at that introitus, if it's a true vestibulitis, we'll use a compounded estrogen testosterone cream to the opening of the vagina. But if we have significant GSM, I'm usually treating with vaginal estrogen first. And if this persists, then adding in that estrogen testosterone compounded cream, or substituting and using a DHEA instead of the vaginal estrogen, since it is a precursor to our estrogen and androgens, or estrogen and testosterone. Okay, dose adjustments are very common. If you're still having night sweats, we can titrate your estrogen up, your systemic estrogen. If anxiety and mood symptoms persist, we can adjust your progesterone. If your GSM persists, we can always add in vaginal estrogen. Or if that's one of your primary complaints, like I said earlier, I'm going to treat that. I'm not going to wait to see if it resolves in 12 weeks or 16 weeks with proper systemic hormone therapy. Because with systemic hormone therapy, it may take 3 to 6 months for us to finally find that right dose that's working for you, as it takes some dose adjustments along the way, listening to your feedback and your symptoms and your lifestyle. And maybe you had an allergic reaction from the patch, or you're just not going to be consistent with the daily gel. And we have to make those modifications along the way. Also, the tissue takes time to heal. So, vaginal estrogen typically requires at least 8 to 12 weeks for you to see the full effects. And then ongoing use is needed, because when we stop it, it reverses, it progresses. So I've seen this before, where patients start taking their local estrogen. And then when they get started on their systemic hormone therapy, they think, oh, I don't need this anymore. And they stop it. And they're reporting that those GSM symptoms are coming back. Maybe they're having some more urgency, or sex is a little more painful or a little drier. Don't wait until your symptoms are severe on this one. And we can see vaginal dryness and these GSM changes even in perimenopause. It's easy to treat early, but it's always treatable. And I think that's really important for us to know. So if you've been thinking, why is sex painful? Why do I feel like I'm tearing? Why am I peeing all the time? Why didn't my hormone therapy fix this? The answer is simple. Systemic hormone therapy is powerful, but it doesn't replace the need for local treatment of vaginal and vulvar tissue. We deserve comfort. We deserve pleasure. You deserve to feel like yourself again. If you want to explore treatment options, you can book a visit at Sky Women's Health in person or virtual, and we can walk through what's right for you and your body. Or you can look for a menopause or sexual medicine provider in your area at menopause.org, find a provider, or ishwish.org, find a provider. I hope this episode empowers you to understand your options, advocate for yourself, and get relief. Thank you for listening. Until next week, be well. This episode is sponsored by Sky Women's Health. If you found this episode helpful, please leave us a review, share this episode with a friend, help others get the information that they need so they'll feel empowered to advocate for their best health.